if we focus on the gallbladder pathologies first, the most important, the bread and butter of a surgeon, the stones inside the gallbladder. Before we proceed, I would like to emphasize, I would like you to understand that why these stones occur inside the gallbladder. My dear friends, stones in the gallbladder can be made of cholesterol, or they may be pigment, or they may be mixed. These stones are commonly seen in females. Fat, fertile, 40 female is generally the thing what we remember for these cholelithiasis or gallstones. Normally, in normal people, we know there is bile inside the gallbladder. There are bile salts, bile acids inside the gallbladder. The cholesterol is kept in a miscible state inside the gallbladder with the help of these bile salts and bile acids. Whenever the concentration of cholesterol increases, for example, a female who is fond of eating a fatty meal, a female who eats a lot of butter, what can happen? If there is defective cholesterol metabolism, this cholesterol concentration will increase inside the gallbladder, and then the bile salts and bile acids may not be able to keep this cholesterol in a miscible state, and then this cholesterol will precipitate and form a stone. So this is how cholesterol stones can form inside the gallbladder. Apart from this, there may be some diseases, especially of the terminal ileum, the Crohn's disease, the tuberculosis. If the terminal ileum gets diseased, we know the bile salts are getting reabsorbed from this terminal ileum into the portal circulation. My dear friends, I would like you to revise your anatomy knowledge here regarding the blood supply of the GI tract. The abdominal part, if we focus on the foregut, celiac trunk, midgut, superior mesenteric, and hindgut, inferior mesenteric. So terminal ileum, which is a part of the midgut, this area has to be supplied by superior mesenteric artery and has to be drained by superior mesenteric vein. In a normal person, 90 to 95% of bile salts are getting reabsorbed into the superior mesenteric vein. And this superior mesenteric vein joins with the splenic vein to form the portal vein. So this bile salt coming into the superior mesenteric vein goes into the portal vein and into the liver. And from the liver, this is excreted into the biliary channels. And this is how the bile salts are coming down into the gallbladder. That means the concentration of bile salt, bile acid inside the gallbladder will be high. And this will not allow the cholesterol to precipitate. But my dear friends, if the terminal ileum gets diseased due to Crohn's or tuberculosis, then this reabsorption of bile salt, bile acid will not occur from this superior mesenteric vein. That means the concentration of bile salt, bile acid going to the liver and into the gallbladder will decrease. So if the concentration of this will decrease, then the cholesterol will precipitate. And that is how cholesterol stones can form inside the gallbladder. My dear friends, pigment stones are related to various hemolytic disorders. If a person is having any hemolytic disorder, for example, hereditary spherocytosis or sickle cell anemia, there will be more breakdown of RBCs. We all know that RBC breakdown occurs mainly in the spleen. That means if more RBCs are getting broken in the spleen, more pigment is getting produced in the spleen. and the splenic vein will be carrying this pigment into the portal vein into the liver. So more pigment is coming into the liver, more pigment is getting excreted into the biliary channels into the gallbladder, so that the concentration of pigment inside the gallbladder will increase, and this will force the pigments to form a stone inside the gallbladder. So, my dear friends, I hope you are able to establish a connection between the spleen and the gallbladder through the splenic vein, portal vein, liver, biliary channels, gallbladder. Also, pigment stones are commonly seen in tropical areas where the parasitic infestations are common. Apart from this, mixed stones having both cholesterol and pigment, they are also quite common. So let's take a look at what these stones are all about. So if we are talking about the right hypochondrial story, in the right hypochondrium, this particular area, we'll be talking about stones inside the gallbladder, and then we'll be playing with these stones, that how these stones can create a traffic jam in the common bile duct, how these stones can create a traffic jam in the pancreatic duct, so that the patient may develop cholangitis or pancreatitis. Apart from this, there might be some pathology, some abscesses inside the liver, pyogenic, amoebic, hydatid. Sometimes there may be intussusception type of thing which may be noticed in this right hypochondrial area. Sometimes a sigmoid valvulus can be seen in this particular area. So we'll be talking mainly about these stories. My dear friends, starting with the bread and butter of the surgeon, cholelithiasis. Chole means bile, litho means stone, osis means disease. Actually, it is cholecystolithiasis. That is stones inside the gallbladder. The different type of stones, they can be related to cholesterol. Generally, in the cholesterol stones, there is more than 50% of cholesterol. These cholesterol stones are pale yellow in color, and they are more common in the Western world, commonly seen in US and Europe. Another type, the pigment stones. These stones, they have got less than 30% of cholesterol. They are brown, black in color, commonly seen in Asian countries. And then there can be mixed stones, wherein there is 30 to 50% of cholesterol, and they are grayish in color. If you take a look at one of the pictures once again, now if you focus on these different type of stones, my dear friends, this what you are seeing is a pale yellow. So this stone should be a cholesterol stone. This stone should be a cholesterol stone, while this looks to be greenish, brownish, black. So this should be a pigment stone, and the grayish one, what we are seeing, these should be the mixed stones. Let's take a look at the process of formation of these stones. For example, if we start with the discussion of cholesterol stones, they are commonly seen in fat, fertile, female, 40. Moral of the story, if there is increased cholesterol inside the gallbladder, or decreased bile salts and acids inside the gallbladder. Now, such a bile is called as supersaturated bile. Supersaturated bile. This is also called as lithogenic bile. However, this can even be associated with diseases of terminal ileum, like Crohn's, tuberculosis. Now, herein there may be abnormal enterohepatic circulation, and because of this, the concentration of bile salts in the gallbladder will decrease, and this will cause precipitation of cholesterol stones. If we take a look at the story of the pigment ones, they are commonly seen in patients with hemolytic disorders like hereditary spherocytosis, sickle cell anemia, now in this case, as we know, if there is more breakdown of RBC in the spleen, more amount of pigment will be formed, and this pigment will be transported through the splenic vein into the portal vein. My dear friends, I would just like to revise the basic anatomy here. For example, if this is liver and this is spleen, now here comes the splenic vein. In this splenic vein joins the inferior mesenteric vein. The splenic vein joins with the superior mesenteric vein to form the portal vein. This is the splenic vein, this is the inferior mesenteric vein, this is the superior mesenteric vein, and this is the portal vein. Now, my dear friends, in this we can nicely appreciate that if because of any reason there is more pigment production in the spleen due to hemolysis, this pigment will be transported through the splenic vein into the portal vein, into the liver, and more pigment from the liver will be excreted through the biliary channels, and this would be going into the gallbladder. So that is how the pigment from the spleen will come inside the gallbladder. Apart from this, these pigment stones are also associated with various parasitic infestations like Ascaris, Clonorchis. They are associated with bacterial infections as well, like the common organisms seen in this area, E. coli. Generally, E. coli associated stones are soft brown. And then there can be mixed stones. Important step in the formation of gallstones is nucleation. While, my dear friends, please note that important step in the formation of urinary stone is crystallization. Herein, I would like to reiterate that if we talk about how these patients of gallstones can present to us, for example, there may be different clinical scenarios. You would be surprised to note that 80% or even more than 80% of gallstones, they are asymptomatic. That means patient does not have any problem at all. Sometimes the patient presents to us in the OPD with history of mild right hypochondrial pain, and sometimes there can be a acute presentation, sudden onset of severe pain in the right hypochondrium. So my dear friends, if you take a look, it can be totally asymptomatic, or the patient have some mild symptoms and presents to you in the OPD, or the patient has got sudden onset of severe symptom and present to you in the emergency. You are the doctor. How you are going to approach? Now, my dear friends, if we take a look at these different scenarios, if suppose the patient is asymptomatic, how you will come to know? Patient would have come to the hospital with some other problem. Let us imagine a 35-year-old lady has come to the hospital with a lower abdominal pain, and she visits a gynecologist. The gynecologist does the examination, and the gynecologist feel that there is some tenderness in the posterior fornix, and the gynecologist requests for an ultrasound of the abdomen, wherein the radiologist says that yes, there is some edema in the pelvis, there is some free fluid collection in the pelvis. In such cases, by chance, when the radiologist keeps the probe in the right hypochondrium, the radiologist may come to know that there are stones inside the gallbladder. But when you ask the patient does not have any problems in the right upper abdomen. This is what we mean by asymptomatic. My dear friends, now the question is, what should be done to these patients? Would you like to operate on this patient and remove the gallbladder? No. Please remember the dictum. We are doctors. We treat patients, we don't treat papers. The paper may say that the lady is having gallbladder stones, but if the lady does not have any symptoms, there is no need to operate on this patient, except in some situations where you feel that this gallstone can complicate. For example, if suppose there is a large stone inside the gallbladder, if suppose there are multiple tiny stones where there is a risk of slippage of stones into the common bile duct, elderly people, immunocompromised people, typhoid carriers, pregnant females, porcelain gallbladder, some adenomatous polyp inside the gallbladder more than 1 centimeter in size associated with a stone, or maybe some hemolytic disorders, or patients who have gone some bariatric surgery or the gastric surgery. These may be the scenarios where you might have to operate even for asymptomatic gallstones. Right? More than 80% are asymptomatic. No active intervention is needed. Now, if you are the doctor who is sitting in the hospital and you come across a patient of gallstones who is symptomatic, majority of these patients will come to you in the OPD. This lady will give you a history that there are repeated episodes of mild pain in the right hypochondrium off and on. When you clinically examine, you may not find anything on clinical examination, except in some cases there may be tenderness on the palpation in the right hypochondrium. When you investigate these patients, you come to know that there are gallstones. Then you plan elective removal of gallbladder, and you can do elective laparoscopic cholecystectomy. While sometimes when you are sitting in the emergency of the hospital, there is a possibility that a patient may present to you with sudden onset of severe pain in the right hypochondrium associated with anorexia, nausea, vomiting, maybe fever as well. Now, this can occur if there is a big stone which has caused a complete traffic jam situation. My dear friends, as you can see here, there's a complete traffic jam situation here. Now, what is going to happen? Will this bile move out? No. This gallbladder is secreting mucus. Mucus will get collected inside the gallbladder. The gallbladder will get distended with mucus. Stasis, open invitation for the bacterial party, and the bacterial party will start inside the gallbladder, and this gallbladder then will become red hot inflamed, and then this lady will be presenting with severe pain in the right hypochondrium. Now, when you clinically examine these patients, when you try to insinuate your fingers beneath the right costal margin, ask the patient to take a deep breath. Patient suddenly catches her breath. This is what is Murphy's sign. Murphy's sign, my dear friends, is something which is seen in acute cholecystitis. It is not seen in chronic cholecystitis, my dear friends. If you take a look here, this is chronic, this is mild pain, but this is acute. Murphy's sign you can be eliciting in this acute cholecystitis. What you have to do is, you have to make the patient stable, start broad spectrum antibiotics, admit the patient in the hospital. If the patient has come to you early, then you can plan an early removal of gallbladder. But if the patient has come a bit late, then put this patient on conservative treatment, manage this patient conservatively. And once the patient's infection settles, discharge this patient from the hospital, call this patient again after 3 to 6 weeks for interval cholecystectomy. So my dear friends, this is how we approach these patients.